For those of you that aren't familiar with Valor, we're a motion capture company that we have utilizing a markerless technology to help, record, assess, and analyze movement screens, or even help within your return to play procedures. And we've been very lucky enough to work with teams like LSU, ASU, some European football teams like Southampton, Fulham, and sort of through my endeavors through Valor and my personal career, it's brought me to people like Jess, who is obviously here tonight to give us a great presentation. Jess is a DBT. He's also done the arduous task of also doing a PhD. So congratulations, Jess, for there. Founder of Rehab Code, and had stops at the New York Knicks as VP of Player Health, Portland Trailblazers as Director of Player Health and Performance, and good old Exos, old stomping ground, as Director of PT. So he's truly world class. So really excited to have him with the presentation tonight. So hey, Jess, how you doing, man?
That was the nicest thing you've ever said to me. I'm gonna just keep that recording and just have it close to my heart. Mike and I go way back, and he's a great phone call whenever I see him calling or texting. And he's got a great company with Evan, and I've slowly been integrating with their system since I met them at a conference that I spoke at.
So as Jess is going to share his screen for his presentation, just a little bit of housekeeping. So obviously his presentation is going to be around that 45 minutes long. After that, we'll have a short discussion, which will then be able to, after that, open up the floor to you guys to ask questions. Feel free to put all your questions in the chat. I've got Evan and the team that are here tonight, and they're going to be going through, and we're going to try and go through as many questions as possible. We've slated about 20 minutes for that, but Jess is willing to go as long as it takes to answer everyone's questions. But yeah, other than that, Jess, I'll hand it over to you, man.
First off, thank you for attending this. It is Veterans Day. All right, we're good to go. There are no vets in the building. That's probably why we're here today, is that we're actively trying to learn. I just wanted to make sure if there was anybody in the building, I wanted to make sure that we were going to highlight them. My grandfather served World War II. My dad was in the Navy, and he told me I couldn't join the military. So that being said, we are moving forward. Okay. First and foremost, we are talking about the disparity in our return to play decision making. Mike was very nice about all the stuff I have behind my name. It's two reasons why. My father never said he loved me, so I had to find a way to feel good about myself. And two, more importantly, I love what I do. And this feels like work, and it is, but I'm also very passionate about my profession that I'm in. So I've been very lucky in life. Okay, so we're going to talk a little bit about the research. And oops, do you guys see my screen right now?
Yes, sir.
Okay, cool. So let's look at the body of research. So if we look at a bibliometric analysis, that is a sexy term to saying we are going to do a quantitative analysis of all the research on a specific topic. So looking at specifically where research is being created from institutes, what topics are being made, and it gives a general consensus of how much research is being pushed out on a topic. ACL is the golden child. It is the favorite child of rehab. So we look at it. This is from an article from 2022. 900 articles are produced annually. So if you take all of them that are not pertaining to a specific surgical repair, 22% are about return to play and the decisions behind that. So my question to you, which is rhetorical, is with all this contribution, with this huge mountain of research, has it made it clear or has it created more chaos? Let's talk about the chaos. We have biology versus criteria, right? This is a big piece. Biology is weighed by the surgeon. This is where they dictate where they think this athlete or patient will be. So think biology as Mother Nature, okay? And criteria is all about father time, right? So we need to balance, because clearly we have to have the biological tissue to do its thing to heal. But then there's a piece of, we can't rely on our surgeon just because of pulling out a timeline to say, yep, in 10 months, this guy's good. We have to have that nice blended approach. Now, I do think we look at some of the research, the Nageli and Hewitt in 2017, very, very polarizing article that a lot of people talked about because it said for the best results, we need to hold out individuals for 2 years. And that was a really tough pill to swallow from a lot of people and medical teams that were involving professional athletes that's going to dictate a lot of things when it comes to team dynamics and everything else. So this was done in 2017. This was a big study. We all talked about it when we read it. Then this recent one gave us a little bit of a sigh of relief. And this was from the British Journal of Sports Medicine. And they looked at longitudinal data of individuals that have had a repair, and they cut them into two sections. One being individuals that were cleared before 9 months, and then individuals cleared after 9 months. And what you find is this really didn't change much when it came to specific, just general knee injuries to that athlete. And they looked at it for 2 years. And then on this end, that right-sided graph, they looked specifically at ACL injuries, and there was not much difference, which is a good thing because I think we need to step back and know there are certain biological timelines I think we should honor. But after that, let's really hone in on the technology piece, basically creating really strong benchmarks to really make sure that this actually makes sense when we clear our athlete. So different repair types, that's another big thing, especially with the quad repair. That is a huge game changer. There's been a lot of surgeons that have used this instead of using the classic bone patellar tendon graft, and there has been some headaches. I don't know how much longer quad tendons will be the preferred or the new kid on the block. I think we're going to move on from that. Hamstrings just kind of always sitting in second place. And then we're always trying to make sure autografts are the preferred tissue. Next on the chaos list is who owns the clearance process? Because are we going with the surgeon or are we going with the actual PT? Now, I think we need to, as PTs, understand that if we can't show a very nice picture of what has happened through months and months of rehab, that falls on you. We can't sit and blame the surgeon for making a decision when we can't even show a general picture of how this patient has progressed. If we're not doing that, we have to firm that up, and we likely should be attending the actual appointment with the athlete or patient so that there's much more of a clear communication and that you guys can kind of work between Mother Nature and Father Time. Another one is the gold standard of force testing, isokinetics. I have one right over there. If you have an ACL, you need to have an individual or a practitioner that has that device that not only can test it, do serial testing, but also possible training. This is still the gold standard after many, many, many decades. And if you don't have a referral source because you can't afford one, you probably should find that out soon. And if you're in Phoenix, come talk to me. We'll figure it out. The next one is the dichotomy of rehab and performance. We have a very, very messy handoff to performance. And it's this kind of awkward dance of like who owns what spot. And most of the time it's the PT that's trying to encroach and say, I want to do the performance stuff as well. And that becomes actually a bottleneck. So I think really good integration with strength coaches and giving them the parameters from their end so that they can train their athletes with confidence. And then there's literally a handoff where now the strength coach kind of takes over and the PT is more of a secondary role, observer, maybe chime in here and there, but there clearly has to be a shift for very good level, a high level rehab. Testing integration within the rehab continuum, I think you really got to establish how you test, in what frequency, how you're going to test it, how you're going to educate the patient so that they know objectively where they're at. And then the really shitty one is the reduction in PT visits. And now that drops the reimbursement. So now you have an ACL that you may only get to see for 20 to 25 visits. And how does that work? It's not a great outcome. Okay, anybody know who this is? You don't have to answer. This is hard to kill. So what's hard to kill currently within this chaotic? This is Steven Seagal, if anybody cares. So the hard to kill paradigm shift. These are the things that are entrenched in our brains that are basically really hard to stop talking about. One is early 2000s, we talked very, very excessively about the hip abduction and external rotation strength and how that it was so critical to minimize genu valgus. It was demonized. It was like, this is the true culprit to ACL tears. Really, guys, the ACL tear is a really hard stick with about 20 to 30 degrees with maybe a little bit of rotation, and the ACL goes. This is a factor. I think we demonized it and we made it bigger than it is. The most important thing is we have to make sure the quad strength is really where it needs to be. The other one is the open kinetic chain. So nobody can do anything that's a knee extension. That was a bad exercise. Surgeons still hail like this is very inappropriate for ACLs. There needs to be a rhyme or reason when you introduce it. But literally, guys, if you're not doing isometrics early in the rehab phase, at 60 to 90 degrees where there is no shearing on the ACL, you're asking them to generate quad strength in the most inner range of motion where they have the weakest and mechanical disadvantage to generate quad strength. So you are literally asking them to do the toughest task with the lowest amount of hypertrophy or any type of change neurologically. I stress to my mentees and people I work with, knee extension, quad sets, that is a range of motion exercise. You cannot consider that strength. That is you just establishing extension. So I think that's important, opening up for full range of motion testing for isokinetics, likely a clearance after the 12-week mark with the surgeon. And as long as everything's good there, you probably can move forward into that testing at that 4-month mark. 3 to 4 month mark. I also think right now, guys, the pendulum has swung. Like we've always kind of went into this movement, and like the triplanar, looking at the whole system. We just looked at the forest. Now the pendulum has swung. We are looking at the tree. Everyone has their trusty handheld dynamometry, and they just focus on torque. And they're using these really great words in physics because that at least we're moving in the right direction, that we're quantifying force. This is great. This is awesome. But let's get this pendulum back and let's honor our eyes, honor movement, honor the technology behind that, along with marrying the outputs that you get with kinetics. I think we got to just step back and look at the full picture. And then the last one is integrating rate specific training. We are integrating it way too late. And this is a study in 2012. It's a bit old, but they found the rate of force development. There was a huge deficit at 6 months. They were almost 40% of a deficit with soccer players, though they were presenting at 97% their max voluntary isometric contraction. So they were showing the totality of force. Their peak was pretty solid at 6 months from an isometric stance. There's clearly other ways you should be testing it, but there was a huge deficit with rate. And I think that's the one thing that we need to continue to do, even submaximally earlier in that middle stage of rehab, so that they can gain confidence, that they know how to fire at faster speeds and integrating that earlier. So current solutions. So I talked about the chaos and some of the issues. Now here are the solutions. One is integration of technology. This is great. We're getting all of this information, motion capture. We got force plates. We have Valor. We have wearable sensor. We have a bunch of things that we can quantify return to play and readiness. You can look at joint angles. Now we're starting to honor kinematics a bit more. This is great. It still needs to evolve. We still need to get better. The technology still needs to improve. We are still encroaching this new, really exciting element of tech. And then instead of just looking at the outputs and capacity, we're also looking at how does that movement look with control. Basically organizing their body through space and time. Upskilling the modern clinician, just like how I said with all the integration, we need to upskill everyone that's in that world of rehab and sport, that they know how to run a force plate, that they know how to do force testing. Gold standards and emerging metrics. Yeah, this is still the gold standard. IKD, find your people, find your partners to kind of work through. But isolated quad torque assessment, very important. Clearly, in the situation with a hamstring graft, that hamstring is very important too. We have to make sure that we're just not focusing totally on the quad. But however, the strength alone doesn't explain the disparity. Decel quality, strategy selection, and the kinetic timing. Bridging, kinematics, let's get some marriage here. So kinematics are basically, looking at the vectors of movement. How do the joints move with space? And then how does it look as you apply more load or more demand based on impulse? Cutting the time in half, what does that movement look like? So Valor's 3D motion capture can visualize the angular displacement, the segment coordination of each body part, and then the mechanical efficiency during high-speed tasks, such as cutting and braking. So we really want to try to find ways to still respect objectivity within the element of sport. And that's something that you can never pull with a force plate or with an isokinetic dynamometer or a handheld dynamometry. So next is to fully understand the return to play process and the sport clearance. There are three major questions. One is, what is the most common mechanism of injury? So step back and say, if I was in Vegas, what is my clinical wager that if something were to go wrong, what would happen? A hard decel, an unexpected defender where you have to make a very short distance decision. In basketball, the Euro step where you have a stiff knee and you're changing to a lateral movement. All of these, so it's that deceleration demand with some kind of lateral movement where you do get some pivoting as well. And then the next question is, what are the sport-specific demands of the sport? So what are they going back into? And then the last question is, what is the confidence level of the returning athlete? So I think you keep those three questions always in the back of your mind, because this is how you're going to tailor your rehab from the middle stage to the end and make it as seamless as possible. So there's a thing in corporate America called pre-mortem analysis. This is basically when they go and have like a project or an initiation within their corporate world, and they all sit in a room and talk about, we're going to roll this out, and the day we roll it out, it's going to die. And then they kind of get the whiteboard and they start to write, what are all the things that could go wrong for this thing to flop? And I think that type of mindset is very much what we need to do when we look at day one of an ACL. It's like, in 9 to 10 months, what are the things that could go wrong that this would actually re-rupture? And then let's pull the onion back to then start to work each phase of rehab to make it make sense. So I have this picture here because it shows the difference in the ground reaction force demand between a deceleration and an acceleration. So 6 times body mass. And it's 168% difference between them sprinting from an acceleration to them stopping. So there is your pre-mortem analysis. If it's going to go bad, it's going to be this. And if you tear it doing this, you sure as hell it was going to happen someday. Because if they can't do it the capacity with concentric, they sure as hell not going to be able to do it decelerating. Timing is off. So they usually have this RFD and this change in impulse and demand of impulse. And a lot of times athletes go, I feel pretty damn good, but I don't have that pop. I still am looking for that pop. That is what they're missing. Their ability to generate force as high as they can in the shortest amount of time. Fatigue is another piece. The mechanics will break down as they get tired. So for me, I like for them to be doing sport-specific training after their ACL for 2 months, building up, getting the capacity. You can do all you want on a treadmill and a bike in a pool. Sport fatigue is different than anything else. So your job is to say, when I clear this player, and let's say they're cleared, but they're still in this return to performance, which is basically they're cleared to be in sport, but they're still just not 100%. This is where you start to have some contextual rules. Like, you're cleared to play, but maybe you're not a starter, or maybe you're in a different position that has less sprinting demand, or you have a minute restriction. Well, whatever that return to performance idea looks like, and that's determined by the medical doctor, you, the coaching, especially if you're in pro sports, like, what does that look like? what's the ramp up through this return to performance, then you can start to ramp up ESD, energy system development, and make sure that it aligns with when they realistically are cleared. If not, maybe a little bit more. Also, previous history of injuries, that makes sense, right? If you've injured yourself once, it's a higher chance you're going to do it again. And then the psychological limiters are very, very important in making sure you test. Here's the quad. I mean, I call it the quad strengthening continuum. It's really just the phases of rehab. The first one is neurogenic. So the first 2 months, this is activation. I want full range of motion, a quiet knee. The quad is on point, can generate a pretty fast contraction and can contract it in the most challenging position, which is full extension. I like to have an extension hold where they hang off a table and they have to keep their knee completely straight with 8 to 10 pounds at their ankle, and they have to hold it for 30 seconds. That is a endurance test in the toughest mechanically disadvantaged position for the quad. So that's activation. Neurogenic is also, I'm putting an electric stem on this all the time because I'm battling AMI, arthrogenic muscle inhibition, the thing that basically your brain says that's not the same thing anymore. I'm going to baby it. And then that just proceeds to the quad just shutting down and not doing its job. And then what happens is the hamstring starts to synergistically hold, and then you start to lose range of motion. Capacity, this is 3 to 4 months. This is all work capacity. So endurance, you're building up body weight tolerance to then using light weight. Everything should be looking good. A step down, a single leg squat, walking should be fine. This is that 3 to 4 month, and it should be quiet, but just constantly looking better. Peak force phase, this is 4 months out. Strength, we're kicking up into that higher 1 rep max. So you're kind of playing in that 70 to 80. You're developing strength. Your reps are down. You're generating that ceiling of force. And then that last bit is 5 to 6 months. It's power. It's rate. Okay. This little line here is called the elephant in the room. And I could even put this thing even at that activation neurogenic phase. We do a crappy job. We're not good enough. So this right here, we hand them off to the strength coach and they're looking at you like, what? This guy can't even like jump. And you're like, what are we doing? So we as PTs have to get this 4 months right. And then having good conversations with strength coach or still be involved, but like starting to get integration into performance. So that's the elephant in the room. That's why I have that picture there. Okay. And then, I think my mom, she thinks I'm beautiful. I don't know about James, but this is just a infographic of the pie, right? The pie chart of all of this is being done. So you might be in 4 months, so you're at peak force, but that doesn't mean you're just focusing on peak force. It's just the pie is generally more specific on strength, but you're still doing neurogenic work. You're still doing electric stem. You're doing work capacity. Maybe you're doing BFR. You're emptying the tank. You're doing some metabolic conditioning as well. It's just that pie changes with the emphasis of where you're at in the rehab continuum. And no, I don't listen to James Blunt. Deceleration demands. This is a great visual by Bowden and Sheehan from 2022. We talked about arthrogenic muscle inhibition, and there clearly is when there's a lack of quad strength, your body will find ways to just land with a stiffer knee. And what happens is there's a huge spike in ground reaction forces, which does a few things, and we'll talk about that in the next. But the other aspect is that impulse, which is basically force being produced through a moment of time. And it's very critical to understand that. So this is a big piece, and you're going to start to integrate impulse and changing the constraints by shortening the distance of certain things so that they have to respond at a quicker rate of force. This right here, Bell study found that the patients presented with low quad strength, so the AMI group, they had greater hip extension strength bilaterally. The shielding, stress shielding of the knee caused the hip to be very strong, and it would just continue to inherit patterns that we don't want, which is kind of that trunk lean, getting more flexion, so you're going to get more glute dominance, or you're just going to land with a stiff knee. So this is a provocative position where your center of mass is back. There's this really angulation of that knee, which is around 30 degrees, which is not the great position for it, versus in this more vertical position, that glute doesn't get to do as much, and the quad has to do more, which is what we want. Here is a visual. Center of mass further back, this moment arm of the quad itself has gotten much longer, which means that this has more demand, this quad, and it's really in a stiff, mechanically disadvantaged position for the knee. So this kind of position is not good. This is clearly a mechanism that you could tear your ACL. Here, right here is when you have more of a trunk lean, or when you have a stiff knee with not a good attenuation through the quad, they visually show the ground reaction forces through the body. So when we look at this second version is much more absorbed through the quad, which is what we want. But just think of all of this ground reaction through the body. So one, if you have an ACL with a meniscal repair or a meniscal scope, that meniscus is just getting hammered. Or that medial femorocondylar bruise that happens, or sorry, lateral femorocondylar bruise that happens with most ACLs, that can cause an OCD lesion, or at least the regression of cartilage on that condyle. So look at all of that. Look at the hip. The hip is taking more force. The Achilles has to do more work. So when we're talking about landing, I stress, and I talked about this already, but the dynamic valgus problem, it's for the majority isn't the problem. It is the inability for the quad to take on force, and it starts to create this, which is the, what is it? The finger trap, right? You put your fingers in here. When you tensile, when you basically create traction or distraction, it tightens up. That's what an ACL does. It tightens up with traction. So when you put your fingers together, it loosens up, and then you can free your fingers. So when you have this huge spike in ground reaction forces, you create a compression. So when you create an excessive compression to the knee, it creates laxity. Just like your fingers are able to move, your ACL now shifts more because it wants to be tensile, and it isn't. So it compresses, and then it pivots, and then it tears. So a lot of this valgus related stuff is more about the compressive nature to the injury, not taking on ground reaction force as well. And then, like I said, you'll likely present with a lateral femorocondylar bruise, a bone bruise, along with the tear, which is what basically happened. Now we talk about the soleus. Soleus is like the knee's best friend, the quad's best friend. And the reason is the soleus, specifically the plantar flexor, but mostly the soleus, it contracts 3 times faster than the quad. And the reason why it does that is, one, it's more of a fusiform orientation for the pennation angle, so they fire quite quickly. And two, it's a type 2 lever, which means it can generate a lot of force. It's mechanically sound, and it can generate. Mike said stuff about my calf, like I could smoke him in at least an endurance calf test. But either way, the contraction is 3 times faster. So that's important because it's the airbag. It takes on force from the ground to help out the quad. Now, the problem is when you land with a flat foot, kind of like that gal here, okay? If she lands with a flat foot, what happens is, one, the calf is in a shortened position, but, sorry, not a flat foot, but more midfoot. And what happens is you cut now the time where that tibia will shift forward. So it's a positive shin angle, but let's say it's cut in half now. So all of that momentum and force being controlled by the tibia is cut in half. So the soleus can't do its job. And what happens is all of that force emulates back up to the knee. So a lot of times this foot position is important. If you land with a good deceleration with plantar flexion and you transition forward, you're giving all this ample eccentric control of the plantar flexors, and it controls momentum. Okay, so now let's talk about how to properly test decel and change of direction. One is, here's our goals, right? Isokinetically, if they can produce 3 Newton meters per kilogram, beautiful. If they can produce 4 to 4.5 Newton meters per kilogram isometrically, perfect. I will tell you this, I have screened over 100 NBA knees. Nobody ever hit those numbers. So just take it with a grain of salt. Don't pull your hair out when your KPIs aren't matching, because they might not be able to get these numbers. So just be aware of that, but that's what we want. Relative to body weight or body mass is more important than LSI. This is much more of a telltale sign of where they're at. And then with this deceleration gradient, so they look to see with distance, how fast can you run for the demand of decel? And what they found was really at, let's see here, when you're doing your 505 at 20 meters, so right around here, you're at about 90% your acceleration. So for you to get full top speed excel, you got to get 30 meters. And for you to get a full understanding of how good your decel is, you have to have a very high level of entry speed from your acceleration. Like, I do understand basketball is kind of in here, 0 to 10. There is never a moment in sport where they go 30. So yes, you can do more specific based on your sport, but then you can also just test the absolute ability for that knee to do it. Because if they can do it there, they can do it anywhere. But yeah, this 505, watch out for false positives, because the evidence has shown that only 55% max acceleration at 5 meters. Clearly, the test is more at 10 meters, and then they test after the 10-meter mark, 5 and 5. But that's just something to understand, that you're not hitting those high accels. So for you to understand decel truly, you probably need to get into those top speeds. Here's an example. This is with Valor's camera system. So a back pedal, now absorbing the force and accelerating through. As you can see from here, he makes a cut. When you look at this, look at the demand. That is not a 505. That is a shallow 45-degree cut. And you can see there's hardly any amount of actual knee flexion that happens, because they're efficient. The cut is so easy to do that they're using more of a stiff knee to generate and be more efficient with pulling through. Now, clearly, you can get in a lower stance to make your defender not know where you're going. Like, you're dropping your center of mass because you could go either way. This individual knew exactly what cut he was going to do, and that really it's not overly demanding to the quad. And if they showed that, that's concerning, because that's a shallow cut. Okay, so we can talk about the penultimate step. This is the step that's the second to last, right? So this is important because it takes on a lot of force and momentum. It dampens, and it's an attenuation. It kind of takes all of that momentum for then you to be able to be aligned very nicely to cut and push off with a final foot contact. So this is the sequence of the skeletal system. And if you had Valor, you'd be able to line up these lines to see where the hip, the torso, and kind of the knee. So that's the big thing. If you didn't have any equipment, I would just say, look at the trunk. The trunk will tell you everything. So here's number 2. She's going through her cut, and she's now dropping into some valgus here. The momentum is pulling her that direction, and now she's tipped more vertical, versus this guy was actually deeper into that cut because he's going to go back to that same direction that those vectors show. Here she's tall because she can't slow her mass. So this final foot position now has to take on much more load than it's supposed to. This foot's actually in the air. So now it's a single leg decel on this limb with a trunk that's not even efficient for the glute to do anything. So if you look at the verticality and the trunk position with these cutting drills, you'll be able to see how at least they're probably struggling. Here's a visual of the ground reaction forces that happen in the last 3 steps. This right here is the anti-penultimum step, the third to last. This is the penultimum foot contact. This is the final foot contact. Understand that this totality of ground reaction forces tells you something. This position of the torso is much more vertical. There's much more speed happening. And then this shows you how important, because it basically pulls all that momentum, controls all that speed and that mass, and controls the ground reaction forces, because it's so much of a dampening step. And then they come off the final foot to push off again. So understand that anti-penultimum, if you're not good there, you're just setting up for a bad penultimum step. And then this third to last step, just know that if you have a meniscal repair, or if you have something that's more inert, that is more of a weight-bearing structure, be aware of this step too, because there's a lot of force. Here, right, is a 505. So they start at the line, they sprint 10 meters, they get an entry speed at this gate they run additional 5 meters, they come back and run 5 out. So very important test because you get this nice continuation. It's a 180 cut, so it's the hardest cut that an athlete will be able to do. And even in basketball, there might be 2 times in an evening where they do a 180 cut. Likely a turnover, they throw it, and then the other guy's running down the other basket, and they have to stop and generate that force. Football's completely different. But I do like that even though it's not sports specific, it is functional specific. It really challenges the amount of capacity and ability to stop. So it's at least a good snapshot of how efficient are they with their brakes. This right here, you can do it in a shorter distance. This is a acceleration decel ability test, but you basically run out and it's from 0 to 10 is kind of your acceleration phase. And then from 10 to 20 is your decel. And you're looking at time, you're looking at distance of where they're able to stop at that line. I think this is the line it should be here, the accel to decel. So it's a 10 meter and then a 10 meter stop. Now we have jump tests. So there's been research to say, hey, what's better? Is it a single leg horizontal hop test or is it a single leg vertical hop test? The research shows that the demand of the knee with a concentric demand is much harder with a vertical hop test. It's also a telltale sign of how strong their knee is. Horizontal hop tests are fine. The propulsion piece of a horizontal hop test is more calf and glute dominant with not much propulsion from the quad. But the deceleration or stopping the landing is more quad specific. But the problem is the quad or the knee lives in a sandwich with the largest muscle in the body, the glute max, and the strongest muscle in the body, the Achilles, soleus, and gastroc. So don't get it twisted. Even though it shows that horizontal hopping's great for decel and looking at the quad, I will challenge that because you can hide a bad knee. So the vertical hop test is really hard to hide. So look into that, integrate it within your testing. It's very helpful. Counter movement, jump test. If you have force plates, that's great. There are so many different metrics you can look at. If I were a few that you could look at is the concentric impulse, and you can split up concentric impulse into P1 and P2. And basically, concentric impulse is the totality of concentric movement from the amortization phase of them going down into their squat. It's the moment they start to generate. So P1 is when they're deep and they start to extend a bit. And P2 is full extension as they get off the ground. And a lot of times with a bad knee, P1, that deeper position won't look great. And what they'll try to do is they will try to catch up in P2, which means their calf and their glute are going to try to do more work. So concentric impulse specifically at P1 is a good one. I like to just jump height's an easy one. RSI is a good one. Depth of squat can tell you a lot. For me, when you're doing a single leg versus a double leg counter, like a counter movement, single versus double, I don't love the eccentric look of a single leg counter movement jump because it's not a natural movement. There's balance. It's a task that's a bit more challenging. I think for you to do a double limb counter movement jump on the eccentric piece, so eccentric peak velocity, eccentric peak force or peak power, those are metrics I like to look at. And for a single leg counter movement jump, I do like more the concentric, the propulsion, the concentric impulse, peak jump height or peak concentric force. So that's just one nuance with the jump test. Drop jump, that is a very short ground contact time. Right? You're getting up as quick as you land off the box and you're springing up. And then depth is much more you absorb it, get some decel, and then generate force back up. So one is a little bit more looking at absolute strength, and then one looks at more of the stretch shortening cycle. Let's see here. I'll kind of break that down a bit more. And then the triple hop test, not a great test. We've had a few people talk about it. My friend Eric Mara has talked about it for a while now. Don't love it. There's a lot of ways that they can get away with it. They can learn to compensate. They can leave momentum in the tank to achieve the task. It can be done subconsciously or consciously. I also think that if you do this enough times, they start to learn the test and they start to become better cheaters. So not an ideal test that I like. It's still something you should do. But I will warrant you this. Stop putting so much emphasis on the distance, because what I find most people do is they test it and they don't even watch them actually jump. They just are looking at the tape measure to see what the distance is. And that's not the reason why we test. We need to look at the kinematics of that. Can we get Valor, throw it on them and look at that? Yes, you can. That's the value of this system, is you can get deeper into the biomechanical demands. Here is the quick little jump here. Very narrow base of landing, and he has something going on with the left hip. As you can see, it's something subtle, but he doesn't go as deep into his left hip. So one, I look at his hip range of motion. I'd also look to see, well, he's maybe he's maybe putting more demand on that side. I maybe look at his ankle range of motion as well. So there's other things. You can look at this and then you can kind of examine what is the issue with the thing that you see. Rate of force. So here's a good visual. This is the thing that I talk about with, you can get slow RSI, which would be anything greater than 250 milliseconds. That is called a modified RSI. And you can acquire that through a counter movement jump. So very easy to get. But an RSI that is fast is you need to do a drop jump or a Scandinavian rebound test where you do cyclical jumps. And each time you get off the plate, you're trying to get higher. So this is measuring rate at a lower, so less than 250 milliseconds. So when we look at rate from 0 to 50, this is neurogenic, it's neurological. This is just nerve endings. You'll not be able to change this. Then from 50 to 100, we are looking more at the contractile properties of the muscle. Is it a type 2, type 1? How quick is the actin myosin bridge, and more of that technical muscle science. But then at 100 to 200, that is where we can train. That is where we can try to make an influence. But know, guys, that from 0 to 75, maybe 100, you're not really touching it. It's either mechanical properties of the muscle or the nervous system. So for me, I just stress that it is very critical to get them to do sport and get them to be exposed to sport specific demands, because hopefully that changes the neurological aspect. It changes the muscle architecture and the efficiency of that, and hopefully the 100 to 200. Yeah. So the return to play should not be a guessing game. Guys, we have these individuals for a long time. I've had more complicated discussions on return to play for an individual that's out for 6 weeks. That's a tougher one for me when I was in the NBA than knowing, like, this is the amount of time we have with this individual. Let's not screw it up. And what we need to do is we need to tie in technology. It's going to guide us. It's going to tell us what they're weak and if they're changing. And then every week you can start to give more feedback to say, I truly think the timeline's it's only going to get you there. So your timeline becomes much more accurate as you get more testing involved. Again, the pre-mortem analysis, what are the things that could go wrong? Well, AMI can kick in. So now you have hip strategies that you want to avoid. If they're inheriting bad patterns, that means the task is too hard, or you need to try to cue it or constrain it in a way where they have to own it the way that you want to. The last thing you want to do is continue to feed a bad system. Also, sport is dynamic, reactionary, and intuitive. There will be a point within the rehab where you're having more conversations with the athlete, and you probably are customizing certain tests that you've never done. But it's because you're having one-on-one combos to say, we are kind of in this past return to participation, now into return to sport. So you're cleared, or you're involved with some of the maybe practice, but return to performance. When you're still not 100%, you are providing micro dosing of certain tasks to get that neural rewiring of the brain and confidence and everything else. So that's where you tie in even more unique stuff. So with Valor, that is much more sport specific. Like you can kind of get them to do things and tie it to their sport, which guess what? They're going to buy into that way more than sitting on an isokinetic unit. So pragmatism is better than idealism. Understand, guys, idealism is if you're creating research. And if you're not creating a sterile research paper on the specifics of a test, I think you need to buy in and introduce some more creativity within your decision making. These are my references. Man, I'm very proud of myself.
That was awesome, Jess. And you know that you've done a good presentation when everyone's still here. Usually when I do one, they're either all asleep or they've left. So well done on that. But obviously, guys, we're gonna in a little bit we're gonna open it up to the floor for questions. Obviously, I can see some people reacting, but if for those of you that not really know their way around Zoom, down the bottom we have the react button, which is third from the left from participants. And if you click into that, you can raise your hand for any questions you want to ask Jess. But while that's happening, I just got a couple of questions for myself. I've been writing some notes, Jess. So, like early in your talk, you said that we've like overemphasized dynamic valgus and lateral hip work, and we've lost sight or we're losing sight of rebuilding quad strength. Obviously, there's people that are attending tonight that may work with various different athletes with different physical maturation, training age, all the way from youth, collegiate to pro, right? As you know, like that is a big difference in terms of how you rehab your ACL. So, if we have like weak hip adductors that drive femoral internal rotation and knee valgus, like at what point do you decide what's relevant to lead with quad strength and what's relevant to lead from hip control within your rehab phase?
Well, I think like you were mentioning, step back, what's their training age? How are they developing? Are they a young teenager where they just look like, a fawn and they're falling over their own feet? Let's work on proximal strength. Get the core set, get the hips engaged. I think that's important. But I would say, especially with an injury, with an ACL tear, take care of the quad. If it is not a situation, let's say you're just screening them out, then you got to get some objective numbers. So get them on an isolated force, look at their quad, compare it to their hip abduction, maybe do a ratio between some of those different muscles, like a hip abduction to adduction ratio, and then a quad to hamstring to see how does it look with the whole system. But if they can't look clean doing a lateral step down body weight, if they look bad with a single leg balance, I'm likely addressing the knee, but predominantly just getting them to look more athletic. And that's the same with having an individual do a yielding isometric, let's say a Bulgarian split yielding, and they're like doing all of this. All right, stop. You're not doing the task that I want. So you either give them, constrain the movement, or it's simpler. Maybe you do more isolated work. Maybe you do an overcoming. Like we usually go yielding, but in a case with overcoming, it's more I'm just pushing into something that doesn't move and I don't have to balance as much. So there's just some contextual thoughts on like looking at the athlete and seeing from your coach's eye what does look like the problem.
For sure. And would you have that differentiated between a PT lens versus a strength and conditioning lens versus a sports science lens?
Yeah, I mean, if they've got magnetic knees, I call it magnetic knees when they're just going like this with body weight bilateral squat. That's not good. If they do it with a single leg squat, okay, let's look to see if it's more quad specific. But that demand is so low and it's a bilateral compound movement with no external load, and they're doing that, that's a hip problem. And
Okay.
I want everybody to know that ACLs are torn with this dynamic valgus angle. It does. I'm just telling you that we overestimated it in the early 2000s when there was a lot of research. I'm not saying who the research was done by, but that drove, and we as PTs always do this, and we stop having common sense and we just start eating the next thing. We like to be spoon fed.
Well, I want to like sort of touch upon that a little bit as well, because you're saying like, hey, knee valgus is being demonized. But I just saw recently, or it might have been a couple of weeks ago, and if AJ's on this call, he knows that I talked to him about this. There was like an individual that was suggesting that knee valgus is often a problem-solving strategy rather than a sign of weakness, particularly within female athletes, when it comes to ACL risk. So what's your take on that? And again, it's like the typical online discussion, but just sort of I thought it was an interesting point.
Again, context is king, right? Women have wider hips, which means they have a natural tendency to go here. So is it a compensatory movement? Maybe it's structural. Maybe it's structure with the type of sport that they're just built, that it just has that tendency. You just got to look at moment arms and how moments change. And if you have skeletal systems that promote that, is it a compensation or is it just a game of physics and that's what leads it? I will say with the cutting, when you have a change in that torso, like you're going to compensate somehow. So that is likely a compensation of some sort. It's basically finding, how am I adjusting my torso, my hip, and my ankle to protect this knee that's not slowing momentum down. So it's probably a little of both.
And what's your take though on like the knee abduction moment that is the force that's critical to the ACL rupture? How do you sort of buy into that within your injury mitigation protocol?
I mean, I have them for a long time. Like, is it an actual patient with an ACL tear or preventative?
Well, either or.
If it's an ACL patient, they're with me. They are in
Mm.
rehab purgatory. I'm doing everything. I'm hitting the hip, I'm hitting the quad. I just think that we don't do a good enough job as PTs. And you love this shit because you're like, yeah, strength coaches. But we are so much like impairment specific how we think. So then we look at our laundry list of impairments of what we're dealing with. So then we take that into our training model. And I say, we will improve accessory movement to ankle. So relative ankle dorsiflexion will change. And then I will load the ankle in this pattern. And then I will do this. And it becomes so compartmentalized like we do with our impairment list, when you're like, what the hell are we doing? Like, let's just load it. And I'm doing multiple positions and testing it. I think when I have an ACL, like I'm exploring all that. I am trying to change the abduction moment of the hip and getting them to have better control, because pre-mortem analysis, I know that that's likely something that happens.
Gotcha. And my last question before we go into opening up to the floor, because there's a couple of people that have asked, but just want to get you to briefly outline like what is your preferred ACL reconstruction graft and how does the graft, help and differ with like how does the rehab differ in accordance to the graft that it is used in the surgery?
I mean, I kind of talked a little bit about it, but in general, let's talk about what this is. Surgeon rips out a tendon out of somewhere in your body. Hopefully, you want an autograft. So they rip it out and they go, okay, we're going to bundle it up and we're going to throw it in your knee. And then what the tendon is basically saying, what the hell just happened? I was cool and now I got no blood flow. It's ischemic and all my buddies just start to die. And then the body looks at it and goes, well, what's going on here? So they start to clear. All this cellular movement starts to pull out collagen 1 fibers and say, you guys are dead. You're dead to me. And then they go, okay, the immature, the teenagers, collagen 3 come in. So now you have this immature that the scaffolding is weak. So 0 to 6, like you're pretty strong early on because the tendon cells are still there. They die. So then from, you know, as you're getting longer into this period, you got a bunch of teenagers holding up this ligament while you're trying to get the ligamentization phase to do its thing. So you have to respect that. And with that knowledge, from 3 to 4 months is the danger zone. If you're going to rupture it, it's these teenagers that don't know what the hell they're doing. They're still maturing. And now you have an ACL that is 30 to 50 times more lax. So I don't know if it's ironic. I don't know if the brain knows the human body, probably so, because, you know, I don't think it's by chance, but usually in the ACL, that 3 to 4 month mark is kind of the ditch. They have a hard time generating force, and it's kind of like, keep your head down, let's keep working, let's work, focus on work capacity. Your peak will get up with time. But I think it's your body instinctively saying, hold on, guys, we can generate force better, but let's get past this teenager. Like, let's get these remodeled to get stiff. And then that tendon now becomes a ligament, and that remodels all the way for 2 years. But they have done research to show at about the 9, 10 month mark, the intra-articular joint starts to look like it once did before. So knowing that, bone patellar tendon has been there for a while. There's been a lot of surgeons that have done thousands and thousands of that procedure. They're really good at it. The problem is sometimes you get anterior knee pain because you've basically pulled off a part of the patellar tendon. So yes, you have that. But the most robust, less shifting, probably the best you can do based on the tunneling as well. So if I had a professional athlete, that's what they're getting. Hamstring doesn't, you can do a quadruple bundle. Now it's thick and it's in the way. It's still not as strong. And not only that, is you've removed a piece of the tissue that now can't control and can't cause that tibia to do a posterior drawer. So you have some neurological changes, which means there might be more shifting, and the tendon itself is not as great. If somebody has a really bad patellar tendon, they've had a history of it for a while, and they tore their ACL, maybe that's the way to go. And then quad tendon, new kid on the block. The problem that I've seen and I've heard from many colleagues is the inability to generate force for a long period of time because of symptoms. And then if you're dealing with AMI, that's a real tough scenario to get them back at an adequate timeline. And what happens is you start to feel pressure from a PT stance to clear them, not when they need to be, but from a biological stance that the surgeon's saying, but they were so inhibited with their quad for so long that they're not ready. So the other thing is there's cyclop lesions that happen a little bit more with some commentary that I've read with quad tendons. And it's because when they remove the quad tendon, there's more fraying. And with more fraying, there's a little bit more fibroblastic activity, which means then there can create this mass. And that's what a cyclop lesion is. It's a extra articular mass that starts to block the ACL. So it's the fraying of that graft. Also, it's a bit more uniform in thickness, which means it also can kind of impede that gliding because you want to have it taper a bit more, but with the quad, it's more uniformal and it's a bit thicker. And that can lead to a cyclops as well. And then you can go, an ALL where you get that lateral stabilization. It's more preference to the doc. If he likes it and he's done a lot of it and he's confident with it, that's not my world. I'm not going to fall on that sword to say, I don't want you to do that. You're just adding more stiffness to that lateral compartment. So it's not a bad thing. It's just more preference to the doc. I would just guide away from quad tendons at this point.
Well, thanks for that. We've now just got some questions in the chat. We got a two-part question from Marcus Pelger. The first part of his question is, what are your thoughts on clearing individuals that are not a 90% LSI extension isokinetic strength, taking into account the quad grafts that are taking longer than the PTG, especially if all other functional tech tests look good?
I'm going to challenge anybody if they can't generate it from an isolated way. Whatever they're doing from a functional is not done right. They are very much masking their deficits. And it's again, because of the robustness of the glute and the lever system of the calf that they can hide it. So if you're really considering clearing them with those not being measured, because remember, LSI is not the best one to kind of go off of. It's relative to body mass. And then after you cleared those numbers, then you pull LSI in to say, what's the LSI look at this point? But really go off of relative to that. Now, if they're at 90%, then they're clear to do certain things. They're clear to be participating in some aspects. It's just probably not clearance to do like live play, but you can start doing drills and getting them to feel confident. And the other piece I would say is sometimes the value of biofeedback where they can visually see like, oh shit, I can push a little harder because I got this thing to tell me. And then they're more confident or they have a game about it. You can gamify it and they might be able to push that to a number that you want.
The second part to that question was, secondly, there's been some papers showing great validity, reliability between cost-efficient devices such as a tin deck, if I'm saying that right, in comparison to a biodex. Do you think using a cheaper, more footprint-efficient device like the tin deck can get the job done for strength testing?
It only gives you a snapshot. I love Tindeck. I use it. I like it more than the Vault devices. It's so practical and easy. The thing that you don't get is you don't get force assessment through an arc of movement. You can do multi-angle isometrics all day long. It only gives you a snapshot of those angles. And I guarantee you, man, kudos to you if you are doing a plot curve system based on 4 or 5 different angles, because you can kind of trace a curve. But in general, you want to see the expression of force through the curve to see where there might be torque decay, which is at the later stages of that curve, or even some kind of plateau early on. The value of the handheld or any isometric tests is you do get rate. Isokinetic tests don't. With motion through, you don't get a rate, but you do get a rate specific metric with isometric. The only problem is it's hard to keep that a reliable test. So for me, I look at it as a general snapshot. And if I'm at the 20-30% range, if I get past that 20, I'm becoming less specific on those numbers. It's more of a general look to get it to a number that is getting in the range that I like. And then it's very nuanced to the mood of the patient, the effort. There's a lot of variables. Did they have coffee that day? All that.
Yeah, so Susan Kang, her question is, when patients are in the middle to late stage rehab and they still complain of, I don't feel my quad working on certain exercises, or for example, I feel my non-surgical side quad working more than my surgical side when going up the stairs. Do you feel that AMI may be part of what they're experiencing?
Yeah. Yeah. It's just a compensation happening. They're using their other limb. And maybe I start to ask their confidence and also know, is there pain that's inhibiting them from doing it? That's a few aspects. But really, when I look at rehab to be a simple man, or a simple approach, because I'm a simple man, go through your table prep, get your range, get some neurological work, PNF, get everything firing. Okay. Then go through some balance, proprioception, compound movements. Let's kind of work through whatever we want. And then at the end, it is dummy proof. We are doing these sets, reps, intensity that I want of isolated work, and we're smoking it. And we're smoking it with safety, but I want that quad shaken. And if you're not doing that at the end, you're losing too much. You're putting too much emphasis on the general movement when you really have to make sure you're honoring both systems. And my friend Kyle Salmons from the Cardinals, he made a really cool thing called the Beast Factory. Well, mine doesn't sound as cool. I also can't grow a beard like him, so I'm still trying to get that.
Well, we all know that you're still 16, so that's probably part of it.
I'm still a type 3. I look like a type 3 collagen fiber.
So next question from AJ Warner. How do you balance the need from stiffness in rapid stops with the need for soft energy absorbing landings? And how do you use ongoing testing data to adjust programming during the ACL RTS phase, particularly in athletes managing concurrent cartilage irritation or lesions?
AJ, you put this in ChatGPT. This ain't your question, dude. I refuse to answer this. Okay, sorry. I will answer it because I like you, but what? Say that one more time.
You know what? AJ, we're going to just unmute you for a second and you can get that verbal diarrhea going yourself.
I don't need to get called out like that. Wow. Gosh.
Man, okay. Hey,
That's two questions. I just Mike
It's
read
a-
it all at once.
you got a great haircut. You got a good look going, buddy.
I'm trying to copy your lead.
So can you tell me the first question? Seemed like
First
soft
question
landing.
was just a stiffness to soft landing. How do you mitigate that? And then the second one was more of a personal question because I'm dealing with it now, is the managing the concurrent like cartilage irritation going forward.
So the first thing is do I want the stiff, or am I having them do different tasks and they're doing that? Mike's just laughing. Get your head out of the gutter. If I want a stiff landing, then I'm going to get them to constrain the task the way I want it. Maybe it's a change in distance so they can't flex the knee. I like kind of drop in plyometrics. A drop in is just dropping in from a height, a drop jump also, because what happens is you get to know that the entry speed is the same. They can't change that. That's gravity and mass coming down. So that's in itself a constraint, because you can figure out what distance they can do and play around with height to make it look athletic. And then for an attenuation, or like Mr. Garza over there would do kind of a deep tier, more flex-based plyo, getting a lot more of that ground contact time, but absorption through the patellofemoral joint and the tendons, right? Then you can go off a metronome where they do it off a pace, or again, you constrain certain parts of the angle where they have to maintain it in this depth, play with the wall and kind of go from there. There's many different things you can do, and that's the value of being creative. But yeah, it's the task that you want it to happen, and then make adjustments. And then for the cartilage piece, you should honor the issue that is more of the problem long term, or like I call it, let the sleeping beast sleep. Let that sucker go to bed. You don't want to wake up the cartilage. So if they can't absorb force with a soft knee landing, you are going to wake the beast up. If not now, in 3 to 4 weeks, when they're doing more demand specific sports work, this thing will start to swell. And now you have a swollen knee with a quad that's not firing the same, and you get a frustrated client. So honor the cartilage, honor the thing that could really steer this whole thing down. If you do have some effusion, get a compression sleeve, have them sleep with it, get them on a bike with the compression, get an active approach to clean out this knee and make sure this hydrostatic pressure gets back to where it needs to be, and then go at it again once that's calm.
They've got a few more questions in the chat as well.
Also, the changing your foot angle, like if you're squatting and you put your feet out like this, like Mike does because he wants to look stronger by doing this with his pose. When you do that, it minimizes the amount of load on the lateral knee, and it puts more load on the medial knee because it can't go into valgus. I'm not saying tibial, I'm saying hips, the whole thing. When you squat this way, you can't go into valgus. So if I have a lateral femoral condylar problem or a lateral meniscus repair, something like that, my graded exposure of squat might be this first. And then as that feels better, I change my foot position.
Yeah, we've got a couple more questions. I hope I'm saying this right, but Max Dobrin just wants to get your thoughts on the cross bracing protocol as a treatment strategy.
Cross bracing protocol. Does anybody know? Give me some context on that.
We can unmute Max and he can explain it to you, Evan.
Oh, so
there you go.
Hi, can you hear me?
Yeah.
Cross bracing protocol is basically a conservative treatment option where a patient would be put in a knee brace locked at 90 degrees,
Yep.
and gradually the brace would be unlocked. And basically that would be an approach to completely heal a fully ruptured ACL.
Well, there's a reason why I haven't heard this, because I've been in pro sports for too long that if I did that, I would be twirling a sign and just hanging out saying like, what the hell happened? So I think it's in a case of like, is this a Coper situation? Like, is this somebody that can go, because I don't totally know on the success rate for that and how stable the ligament is for it to fully heal. And there's clearly the bear procedure now that they use kind of a callus version and let it grow without you ever having to do anything with the ends. you're trying to create a natural healing, like you would say, but it's, clearly it's a surgical procedure on that end. I just think if it's anything that's cutting or multi-directional sport, it's probably not the best. But I've also have athletes that are coping without it. And it's maybe not so much the protocol, it's just the person.
Okay, thank you. And since I'm here, one more question.
Yeah.
Which thing in the rehab process kind of you feel is the most trickiest when it comes to ACL rehab?
I think there's flavors. That 3 to 4 month mark is tough because there's harder for them to generate force to kind of work on peaks. So I kind of stay within that 60 to 70% one rep max and really just focus on angles that they're still showing weakness. I would also say just some of that, like the rudimentary decel work is fine, but the more complicated pivoting stuff later at that 6 to 8 month mark is tough. But my job is to expose them in simpler tasks that are leading to that. And hopefully I've done that a good enough job. But Max, the problem is sometimes you don't see the athlete enough to get that exposure that you want, or you're having to do it from a remote style. And it's just not the ideal rehab process. But yeah, I would say the 6 to 8 month mark when it comes to movement integration, and then more the force production challenges at 3 to 4.
Okay, thank you very much.
Yep.
Great.
Thank you.
Now,
Thank you for informing me of a new thing. I got to look into it. Maybe it'll be on my newsletter.
Well, I'm subscribed, so can't wait for your analysis.
Mm-hmm.
collaboration we didn't know we needed. So we've got Brady Kurtz. He's going to be he's got his hand up, so we'll get him next.
Hey, Jess. Yeah, awesome presentation. Appreciate it. I feel it was kind of a long question to kind of, or be able to put in writing here, but I guess, I have a question. I guess, if I'm to a point where, maybe call it somewhere between the 16 to 24 week mark, 4 to 6 months, we're doing quite a bit. And I'm still trying to, figure out how serial testing, appropriately fits into, the kind of the testing process. At this point, like, obviously we outsource for isokinetic testing. We don't have a biodex in-house, so that's not a huge consideration. I still prefer to take like an isometric test. I'll usually do an iso rate test. But at that point, I'm, if it's appropriate, I'm jumping them. We'll use like a Kaiser knee extension or leg press to do kind of like load velocity profiling on an athlete. And I guess my question is when there's multiple things that we're tracking, and I feel I find value in all of them, and I want them to be consistent across the entire continuum. For an athlete that I maybe have 4 times a week, are you trying to control, like, does it matter? Are you trying to control that they are in here on Monday at 2 p.m. and I'm doing their strength testing on Monday at 2 p.m. every single time? If there's 3 to 4 different things I need to test, like, do I still trust the jump test after I've already done all this strength testing? Or do you prefer to kind of like, try to hit these points in time? Maybe we're doing one, set of tests a day. We're doing more functional tests that's maybe happening later in the week. Because I've found that there have been times where it feels like, you may see a drop off in, the not, I won't say the quality of movement, but, if we're trying to do 3 or 4 different things a day with quality, that can sometimes take a, half or most of a session to go through some of those things. And is the stuff happening at the end as quality as the stuff happening at the beginning? The
job that you need to do, the job that I need to do, and the job that I teach my mentees, make things simple. We complicate, we are the greatest of the great to make things more complicated than they really are. So sit back and say, where were my week to week KPIs hit at 3 months? Are there any lingerers? Are there any things that caused a hiccup? They might be good, but I'm still checking up on the hiccups that happened before, just to keep it honest. Okay, 4 to 6, that's strength. We're pushing the ceiling. We want a larger peak. Look at max isometric testing. Where is their peak at? I don't care about rate so much. I'm introducing rate-specific exercises. I don't want to continue to drown them with testing that they either get frustrated or they get latched to it like It's the only thing that they care about. So 4 to 6, I need to see their numbers go up in the weight room. Like, what are we doing cluster sets? Are we getting some higher loads, giving them a little bit of rest, but we're moving the needle with total tonnage? Track tonnage, track those things. Those are sneaky ways to keep getting metrics, but not getting so stuck on Vald. Sorry, Vald. But 4 to 6, I think isokinetically, there's nothing that can make it better than that.
Yeah.
I would train and test with that because that's the mark where at that 6 to 7 mark, you want that looking pretty clean. So you train for the test and you test for what you train. So I would do isometric testing to get the peak. I would look at tonnage. I want to see everything going up in weight, and then maybe a force plate jump maybe once a week, and serial testing of isometric maybe 2 to 3 times.
Nice. Sweet. Thank you.
We have our last question for the evening from Maxwell G. How have you dealt with CNS fatigue throughout ACLR rehab? Athlete has a huge drop off from 80% LSI to 50% LSI and poorer landing, jumping mechanics from one day to the next.
I mean, when you have that significant drop, I don't know if it's CNS. I think we need to have a conversation. Are you being honest with me? Because I think you're dealing with pain, or you're dealing with some fear. It's either fear or it's pain that you're not like being vocal about. And those type of drops those are the concerning things. And those are the things that when I get someone on an isokinetic, like maybe not an ACL is kind of like a plateau, but like a generation drop and then pick up. That is a classic OCD lesion. It hit the pothole and it couldn't generate any force. So those kind of huge swings in force production or swings in changes within 2 or 3 sessions, I would just check. 1, is it swollen? Is it just not firing because it's more puffy? 2, is it pain? 3, are they confident? Are they frustrated? Are they being honest with you? And then if it is true CNS, you're dropping the hammer on this dude, which maybe that's a good thing. But I would step back and say, how much work am I putting? Maybe you may not think it is, but this person is probably undertrained. And this whole fluctuation is probably just a capacity issue.
Awesome, Jess. That was like great presentation and also great questions from everyone. I really appreciate you. For those that attended tonight that want to get in touch with you, chat with you more, or ask it further questions, like what's the best way for them to do that?
Well, I get to see the list, and I see all these people that either have done my mentorship, have seen in conferences. I got an old boss that I respect the hell out of. Like, those are great moments. Yeah, I called you out, Victor. Oh yeah, Chris, my guy Chris. I would just say get on Rehab Code on IG, rehab_code. I teach courses, guys. I teach on the knee. I do weekend courses. I do mentorship to mastery. It's just like this. And everything that we talk about is questions that you ask. I don't create anything. I am just an open book, a resource. I get the questions, I prepare in advance, and then it's a great experience. Okay.
There you go.
Hit that QR code and that'll get you to my link tree of like my newsletter, my career codex, which is me trying to get you jobs, because one day you'll get into pro sports and then you'll hire me as a consultant. And then that'll make me very happy because I don't have to be in pro sports, but you can pay me. And then I have a few free articles that I review, and then my website and the courses that I teach. Anyway, I'd love to continue to have conversations with everybody that joined today. And it's probably easiest to either talk to me via IG or LinkedIn.
Well, thanks again, Jess, and thanks for everyone for attending tonight. Obviously, we've gone about almost half an hour over time, but obviously everyone was engaged and really appreciate it. Just some sort of closing housekeeping, if you will. We have recorded tonight's webinar, so look out in the coming days. We'll send you an email with a link to the recording, so that it'll be exclusively for those that have signed up, and then it will be out to the public in about a week and a half, 2 weeks time. For those of you that are interested in learning more, obviously, about Valor and what we do, we'll also provide details for you guys to get in touch with myself and Evan and the team if you're interested in learning more about Valor. We're also doing another webinar in December with another one of my really awesome mentors, Bob Valeo. So he's a strength coach of 40 years, worked in college, Major League Baseball with the U.S. Olympic team, and he's going to be talking about all sorts of things from the state of the profession, strength and conditioning, speed, mechanics, and just lessons learned from his time in the last 40 years, which is a long time. It's almost as old as Jess. But yeah, he'd love to have you join and answer all of your questions. But yeah, really appreciate you guys, and we will hopefully see you on the next one.
Thank you, guys.